Hi, thank you so much for joining our webinar this afternoon. I'm Kathy Kennett, PPMD Senior Vice President of Clinical Care. Today we're joined by the team of FibroGen, who will bring us up to speed on the progress of their new compound, Pamrevlumab, a summary of the PRAISE study of this drug in idiopathic pulmonary fibrosis and their ongoing clinical trial in Duchenne muscular dystrophy. Before I introduce our speaker, please note that everybody is on mute. If you have a question, please type it into the box on your screen. We're going to try to keep all of our questions until the end of the webinar. To introduce our speaker, it's my pleasure to welcome Elias Kuchakchi. Elias is Vice President of Clinical Development, Drug Safety, and Pharmacovigilance with FibroGen. He joined FibroGen in 2014, bringing more than 25 years of experience in product development, drug safety, and clinical practice. Previously, he served as Executive Medical Director, Safety at Amgen, supporting the development and commercialization of among other programs. Prior to his transition to industry, Elias was practicing physician with specialization in surgery, having earned his medical degree at Damascus University. It's a pleasure to have you with us today, Dr. Kuchakchi.
Kathy, thank you for the kind introduction. It is a pleasure for me to be here, and I would say good morning to everyone who's on the West Coast, and good afternoon for everyone who's on the East Coast. It is an important times in our clinical development of Pamrevlumab. Pamrevlumab, as you know, that has been ongoing in development for a period of time, and in multiple indication, not a single indication. We have developed this product as an antifibrotic, and we started our endeavor in developing this product in IPF, idiopathic pulmonary fibrosis, and pancreatic cancer, as well as in Duchenne muscular dystrophy. Currently, we are enrolling still in the Duchenne muscular dystrophy and non-ambulatory in this young man that is needed additional therapy. And we hope that this Pamrevlumab in the near future will bring a new hope to these patients. So just to give you a little background on our product. Pamrevlumab is a monoclonal antibody. It's an antibody that has been used for antifibrotic diseases, and it is to prevent the fibroproliferative disease from its continuing. We completed multitude of studies, 11 phase 1, and we completed phase 2, and as I mentioned, in these 3 other indications, in many other indications. So far, we have over 614 patients who are exposed to Pamrevlumab. 520 of them, we are sure that they receive Pamrevlumab, and the rest is possibly received the placebo or other therapy. And majority of this patient receive 6 months or longer. And I'm proud to say that we have even a few patients who received the product up to 5 years. And that is because of that is the next bullet on this slide, which is the safety. What I see here, it says for us to be able to continue to do this for that long of time, the safety signals have up to date was a very benign. There was no risk have been identified with this product. We have not identified a dose-limiting toxicity. And although as this product is a protein, as a monoclonal antibodies, we are concerned about the infusion reaction. So we monitor seriously for these infusion reaction. And so far, all these infusion reactions were mild and moderate in severity. In pancreatic cancer, so far, we completed 2 studies. We completed the study, which was a dose findings, phase 1-2. And in that study, we enrolled 75 patients. Currently, we have another pancreatic cancer study that is enrolled 37 patients. The study completed enrollment at 37, and the analysis of the data is still ongoing, and monitoring in this patient is still ongoing. The biggest program we have so far is idiopathic pulmonary fibrosis. Previously, we completed a phase 2 study with 89 patients. This study was pivotal for us in the development of Pamrevlumab. This is where we identified that we can truly have some patients who show that reversal of the fibrosis. And at the same time, following for this study, we went into a different level of development when we started a placebo-controlled study in Pamrevlumab in IPF. This study is completed during 2017. We analyzed the data and we presented our data at European Respiratory Society meeting in Milan, in Italy. I'm going to take some time here to just show you the result of PRAISE study. In this study, we enrolled, as I said, the patient in an active arm and a placebo arm. The study enrolled 103 patients. So we have to ensure that these patients are in the two arms are very similar. If you take a look at the variability and the characteristic of the patient, almost everything is the same. Although we have some little bit more female patients in the active arm, in IPF, this is work against the product. And you will see later on at the result. And everything else, specifically when we take a look at the diagnosis, everything in this study was balanced. What's important in this study, the study was run as a safety and efficacy. So it's important to mention the safety of that we identified in this molecule during this trial. In this trial, we are seeing that is the patient who experienced adverse event during the treatment, during the exposure to the investigational product, either placebo or Pamrevlumab, it's balanced. If you take a look at the rate, it's 96 to 98, 96% in the Pamrevlumab arm and 98 in the placebo arm. The severity of this adverse event is important, and if you take a look, it's only 10 to 8 as this event was a grade 3. In the grade 4 is the same similar things. The one of uniqueness of this study that we identified, that is, and this is a rare disease with fatal disease at the same time. We had a difference in the fatality in this study between the two study arms. We reported 3 deaths in the active arm versus 6 in the placebo. And it's important to note that the patient who discontinued the study from a serious adverse event showed a similar direction. Only 3 in the active arm under Pamrevlumab and 7 in the placebo arm. And I want to reemphasize the infusion-associated reaction. We have seen even infusion reaction in the placebo, which is only saline. So that has given us a lot of comfort about the safety of our molecule that is we are continuing to develop. If we take a look into that list of, as we said, it is balance of adverse events, you can take a look there. These events is listed in here. Although in some cases you will see some rate is a little bit higher than other arm, this is the rate is a reflection of the size of the study. The one important part to note in here, IPF, one of the major symptoms is cough. Cough reported lesser than what's reported in the placebo. Although this difference is not statistically significant, but it's an important element that we will be looking at into our next development of Pamrevlumab in this population. And none of these events was seriously enough that is to be considered or unique enough to be considered as related to the product. Now we have a very good confidence in our safety of this molecule. What's important for us is to take a look at the biological activity of this molecule. How did we do with this patient? How did we help this patient? Whether there is any good response. This is very important. This is to show the result. At the primary efficacy endpoint is what's called FVC % predicted. Forced vital capacity is a lung function test. And then the forced vital capacity in our active arm, the patients have a reduction of 2.85%. While the patient who took placebo, the reduction in the vital capacity with the mean the reduction was 7.17%. This is to give us a difference between the two arms of the study at 4.33%. This is statistically significant. How we know that, if you take a look at the p-value, and you will see that is below 0.5, that will tell you it is statistically significant. And we have a relative difference between the two arms of 60%. That means the patient who received Pamrevlumab declined less than the patient who declined in the placebo by 60%. The other good measurement is to do is to take a look not only at that percent predicted, is the true volume of when the patients are breathing while on the product. How much that decline from the fibrosis that is continued to insult these lungs. In the active arm, we have a decline of 129 milliliters compared to 308 milliliters decline in the patients who received placebo. This is more than double the rate of what's the decline in the active arm. If you see the relative difference is around 60%, it's similar to what we have seen even in the percent predicted. And the p-value, as you see, it is below the 0.05. It has 0.025 almost.
Elias, this is Kathy. I just wanted to clarify and remind everybody that this is part of the PRAISE study, which is not Duchenne, but it's the study that you did in idiopathic pulmonary fibrosis.
That is very clear. It is in our the line, if is what we say in the top of the slide. The title of the slide will say clearly that this is a PRAISE study, what we are completed in the IPF study. Because we have not completed any other study with a placebo control, or we have not completed a study in Duchenne, or in the pancreatic cancer, and then the first pancreatic cancer that is completed earlier.
Absolutely. Thank you so much.
So what is our conclusion from the PRAISE study? That we've seen a significant improvement in the lung function. We've seen differences in decline in death in the patient who declined severely. I can tell you the patient who declined more than 10% or died on the study, there was a differences over 60%, is exactly similar to the difference we have seen in the FVC or FVC % predicted. We have seen that this drug was well tolerated. We have not seen a signal, we have not seen a patient truly declining treatment or stopping treatment to adverse events related to the drug.
Elias, can you stop just for 1 second and maybe clarify what the FVC is for people who may not know?
The FVC is a forced vital capacity. It's when the patient is go on a use in breathalyzers where they have to breathe through a specific spirometry method, and this could be measured. This is monitored by a specific respiratory tech. We're doing a FVC assessment in our Duchenne study at the same time. Respiratory assessment in Duchenne is important similarly as in IPF, because the fibrosis could be affecting the muscles that could help that breathing, specifically the intramuscular and intravertebral muscles that we can use in helping the pressurize that similarly to the diaphragms that we know that get affected by fibrosis. So this test is not only done for idiopathic pulmonary fibrosis, it's been used at the same time in Duchenne muscular dystrophy.
Okay, thank you so much.
Now we can say, first of all, that is for the first time, FibroGen, although have many proof of concept previously on some biological activity for Pamrevlumab, but none of them was tested in comparison to a specific other treatment or in specific to placebo. Now we know that we have proven a biological activity for Pamrevlumab. So let's go and talk about Duchenne specifically. This schematic is a very important. This is to help everyone understand how the Duchenne is occur and what is the problem in the muscle fibrosis that is and the damage that occur. We know that this is in the and I'm going to use the arrows to show. This is the muscle fiber that you're talking about. This is the muscle fibers get affected, and this get protected at the same time from damages. But there is a lot of things that could come and cause the damages for these muscle fibers. And if we follow this, if we have an increase from the insult that sometimes is unknown, in Duchenne muscular dystrophy, it could be specifically due to mutation. In other diseases, could be to environmental. That could cause it to release of a lot of inflammatory points. And I can show this is what I'm talking about. The macrophage, the cytokine, the growth factors. This would lead into a stimulation of the myofibroblast. In the normal process, the myofibroblast continue to do specific fusion when you have a very healthy level of all these cytokines, growth factors, lead into a normal myelic fiber, muscle fibers. Now, when this process has become persistent or become over the normal level, become pathological level, that is where the damages occur. And when this damage occurs, there will be an increased accumulation of the fibrotic process. In place of being developed into a normal muscle fiber, it will be developed into a fibrotic, have lesser function than the muscle fiber, and destroy the muscle fiber at the same time. That is the whole idea. It is what we have to do. We have to sort of slow down or reverse this process to retain back or bring back some additional normal activity of these muscles. So here is as we see somehow that CTGF, which is we call it a collagen growth factor. And in reality, is not a growth factor. Growth factor mean it's a hormone. CTGF is not a hormone. It's a protein that circulates. It is have a healthy effect and can have a bad effect. When it is at normal level, you will see how the normal look of the cells in the human cells. When it is become about normal level, you will see the collagen is building up. And you can see that in this more prominent red lines that you can see around the cell. And you can see the damages that the fiber has been forming. And if you take a difference between the fibrotic level between the normal and abnormal, you can see the difference in here. It's less than 10% in a normal person, where it could exceed 50–60% in a diseased muscle or lung. If you take a look at the CTGF as a gene expression, you will see that the CTGF gene expression in a normal cell is a much lower than in it is a patient with a mutation in the DMD. So here, as you take a look at as an example in the CTGF, and you will see it in not only in the CTGF, you can see it in all the other in pathways that can cause and increase the CTGF and increase the fibrosis. There's many of these pathways. TGF-beta is one of them. And if you take a look at all these, so everything is highlighted in dark and black. It is if a patient, and everything is highlighted. It's not highlighted. It's in the plain. It is a normal. You can see that big difference between the two. So that is what leads into the increase in fibrosis. Fibrosis is very important if we think of a normal wound healing process. In a normal wound healing process, we need a CTGF to help rebuild the fibrosis to heal the wound. If that normal healing process, which is go through this cycle, is never stopped, if it's continued to build up. As a simple example, a skin cut will require a normal healing process for that skin to reconnect, and that fibrosis connected to part of the skin. We know some people that when they have a cut, in place of building only a normal healing, they would build a keloid, a huge amount of fibrosis that continue because the wound healing process don't stop. So how we do this, how can we stop that and bring it back into a normal healing process? We need to block the CTGF. The CTGF is a key element in the wound healing process when it is at a normal level. The problem with it when it's going to pathological level. So when we are blocking CTGF now, when we want to think about blocking CTGF, we want to at the same time consider that we cannot totally block CTGF. Otherwise, we can block the normal healing process. And this is what CTGF is, the Pamrevlumab does to prevent the fibrosis from continuing. Go ahead, please.
Sorry, Elias. This is Kathy again. So is this a similar process with what happens in idiopathic pulmonary fibrosis, or is this a different process? I guess I'm trying to...
So I was going there to say fibrosis process is the same in every insult. There is no difference in the fibrosis process. In every fibrosis process, CTGF gets elevated to a level it is abnormal and continue to stay abnormal and never stop to go into normal levels. This is what happened in pulmonary fibrosis. This is what happened in Duchenne muscular dystrophy at the same time. Surprisingly, this happened at the same time in pancreatic cancer or other cancers, because a lot of people think cancer is only a mass of tumor, and that tumor or cancer cells. That tumor is multi-layers of different fibers, and fibrosis is one of the major mass of that tumor. And that's why...
Yeah, that's really interesting. So regardless of why the fibrosis happens, all fibrosis involves the connective tissue growth factor, and inhibiting that connective tissue growth factor in whatever diagnosis it is, you are hoping will inhibit the formation of fibrosis, correct?
This is correct, and we have proven this in multitude of other diseases. We tested this not only in Duchenne muscular dystrophy and idiopathic pulmonary fibrosis, in pancreatic cancers. We looked even into the heart muscles. We looked into the vessels. We looked into the kidney. The patients who suffer from diabetes will have a kidney fibrosis from the diabetic insults. And the process was the same, and the CTGF level will always be higher than normal.
Okay, thank you so much.
So that's why Pamrevlumab's role is here, as you can say, crucial, because the CTGF has become like a node that can affect that fibrosis and continue the response from the insult to form the fibrosis. And CTGF continue to be a very critical element, and that's why Pamrevlumab is going to be playing a critical element if successful and approved in blocking the CTGF and helping these patients.
Okay, thanks.
So this is a schematic of a Pamrevlumab treatment, what this possibly will do. And you can see the muscle fibrosis. The picture is on the left. You can see the fibrosis is started to build in between and start to separate the muscle fibers. And these fibers could be vascular fibers, could be a smooth muscles, it could be heart muscles, and there could be many others. Pamrevlumab treatment have to do two things. First part is to stop this from continue to progress. And the other part we have seen, and I'm not saying this is always the case, but we've seen that reverse that. That means it's helped the other element that it can go and dissolve this fibrosis, such as macrophages, that's the T cells. Let's go into this area and start to clean it, and we start to see a reversal of fibrosis. But the most important part is the stopping that progression of the fibrosis. So as Kathy was asking the question, and here is part of your answers. The CTGF is associated in fibrotic response of many organs in the body. As I mentioned, heart, vessels, lung, muscles, kidneys. And similarly, when there is additional tumors is being developed. A CTGF, we know from our studies and from our preclinical studies that we have, it is elevated in human DMD later on, so we assessed in the human DMD. Similarly, and it was well published So TGIF show that it can induce a dystrophic phenotype and even in normal animals. That means if we go and induce the CTGF to be at higher than normal levels, we start to see a dystrophic phenotyping in these animals. Similarly, we went and run a MDX, which is MDX is a specific type of mouse that we can mimic Duchenne muscular dystrophy in these mice to be able to study it. When we did this study and we treated some of these mice versus others was not treated. So one was treated with Pamrevlumab, we've seen attenuation of the disease damage to the tissues. And this is exactly what I was saying, that you can attenuate some and you can prevent some. We've seen that loss of a muscle strength was different between the animals that has been treated versus not treated. We've seen difference in their stamina during their exercise. And this is where we hypothesize that is where you have a inhibition of the fibrosis, and DMD can do multiple things. It's not only just preventing the disease from progressing, it's possibly increase the motility of the muscles. So this is contractile capacity of this dystrophic muscles is increased. And we've seen by controlling them, CTGF and controlling the fibrosis, we can even start the process of doing some reversal of fibrosis. So what's the goal of our study in currently is running in Duchenne? Is to assess, first of all, and I'm very proud to say, usually when we start a study, it is concerned for safety and efficacy. Our confidence in the safety of our molecule, we decided that this study will be run as an efficacy and safety. So we made our primary hope that this study can help us show an efficacy in patients, in this young man was living with Duchenne and they become non-ambulatory. So far we have now given our trial in a Duchenne non-ambulatory study a name. Hopefully we will find a name that can bring hope by itself, similar to praise. That is by itself another hope and that brought into the IPF patients. We gave the study number, was study 079. This study is an open label, single arm. That means there is no comparator in this study. We'll enroll up to 22 patients, non-ambulatory, at the age of 12 and older. And the study, as everybody knows, is PPMD has been a very good partner with us to spread the word about this study. It's still enrolling. Currently, we have 13 young men enrolled in this study. And each patient receiving or will receive the 3019 Pamrevlumab by an IV infusion. We give this drug at 35 mg per kilogram every 2 weeks. The study is now extended to be 104 weeks, 2 years. When our plan in this study that we will be running an interim analysis to prove if we have seen any good efficacy signal, not only safety signal. I can tell you from safety, we monitor for the safety of these young men on daily basis. We review the data. We monitor for every single adverse event or serious adverse event is reported. If we've seen a very positive result during our interim analysis, here is saying around 12 subjects, possibly could be even less. But we should have at least a minimum of 10 patients in the study that have completed 1 year of treatment before we can be able to say we have seen anything. And if the study shows reasonably good signals, will be extended. Our current thinking in assessment that is the study will be extended to 32 patients to be enrolled. But the interim analysis will be the defining point exactly how many additional patients we will need in this study. So, as I mentioned, that it was a study we will be assessing efficacy, safety, tolerability, but additionally we assess the pharmacokinetics. We want to see when we're giving this drug into our patients and this young man, how that drug is maintained in the blood. What's that level, if different from one patient to another patient, and how that difference is affecting the results. This is what we call by our pharmacokinetics, but we will take a look at it not only from pharmacokinetics to understand the level of the drug. We will look at it from pharmacodynamic to correlate this level of drug with the benefit we have seen. Kathy asked me about the pulmonary functions, forced vital capacity, as I mentioned, FVC. This is one of our efficacy endpoints in this study. Maximum inspiratory flow, maximum expiratory flow, peak expiratory flow, peak cough flow. I can tell you all these measurements is testing the lung function. If we're going to put them as in one term, is we're testing the lung function. We want to make sure that all the muscles that supporting the lung function, in this case, the lung itself in the Duchenne is not the one is affected. The respiratory muscles who are affected. So we want to see that these respiratory muscles are responding to the treatment, stopping the decline, or slowing the decline, or even we hopefully on the longer term we see a reversal and we see that this FVC numbers go into the positive direction. I can tell you in idiopathic pulmonary fibrosis, we've seen patients that they're reversed their FVC from going into the negative direction to go back into the positive direction. The other things we will looking at is the muscle function, the function of the upper limb, grip, pinch, the Brooks score. I think everybody is familiar with these. We are doing an MRI to see changes in the muscle fibrosis. Not only in the biceps, we are doing at the same time MRI of the cardiac fibrosis and then monitoring for the cardiac function. Inclusion criteria, I started saying this study is enrolling patients 12 years or older, non-ambulatory, with a Brooks score less than 5 or equal.
Elias, can you maybe talk about what the Brooks score means?
Kathy, I'm going to pass this because I have a flight to take and I needed to leave. I will ask later on for either Gustavo or whoever it says here can go through the Brooks score.
Sorry, okay, perfect.
I'm sorry because I have to be out of here by 11.
Okay.
We mentioned the spirometry that we do the FVC, have to be able to perform it, have to be able to undergo an MRI test, and either for the upper extremity and the cardiac MRI. The FVC percent predicted have to be between 40 and 90%. We have to have at least one historical FVC percent predicted in the last 15 months as a baseline. The heart ejection fraction, which is this we measure the capacity of the heart. It is have to be about 45%. For patients who is receiving a cardiac medications, have to be able on a stable, have to be on a stable regime at least a minimum of 3 months prior to screening, not prior to the study. And if they are in a stable dose of, they are on corticosteroids, which is the majority of the Duchenne patients, have to be on the stable dose for 6 months. Well, who's the patient who cannot be enrolled in this study? Patients who require ventilation more than 16 hours continuously. Patients who are expected within the 2 years to have a spine surgery. Patients with uncontrolled heart disease. Require an IV diuretic as an example. Or the patients who are hospitalized in the last 3 months for heart failure. Or a patient with arrhythmia requiring antiarrhythmic drug. Patient with respiratory failure. Patient with uncontrolled asthma. And this is necessary to remind you that is one of the tests is the cough flow. That's why uncontrolled asthma is excluded. BMI equal or about 40, or weight that exceed 117 kilograms. The BMI is body mass index. If anyone is exposed to a previous investigational product for should have to have enough washout period as for 28 days prior to start of the treatment, or 5 half-life, whichever is longer. So if the 5 half-life of the experimental treatment has been used, let's say, if the half-life is 2 weeks, that means 5 half-life, 10 weeks. So they have to have that 10 weeks washout before screening. During the screening, there is a procedure that has to be done. And then following the screening, there is a safety follow-up. And the study procedures are listed in here. As I said, there is an infusion every 2 weeks. There is safety labs that is going to be taken. That means there is blood draw. There is vital signs have to be taken, weight and height, physical exam, muscle function test, and this is all being defined at which week. And you can see the numbers on the screen. Pulmonary function test, the FVC, the cardiac and upper arm MRIs have to be done at week 52 and week 104 or end of treatment. EKG similarly. And there is a questionnaire on the quality of life. This is important for us to understand if there is a changes to the positive or negative of the quality of life of this young man. So some additional blood draws for the PK is only for the first 12 patients, which is we exceeded now the numbers, and we don't think we need any more PK subjects to ever enroll in the study. This additional blood draw that this is a little bit more intense at day 0, day 2, 4, 7, and 10, and they will follow up week 2, week 26, week 52. This will no longer required for any patients who will be enrolled in the study. The visit to the clinic will be every 2 weeks. So that typically the treatment is taking 2 to 3 hours. This is different from patients population to different patient population. In that Duchenne muscular dystrophy non-ambulatory, due to the fact that they know that they have some cardiac decompensation, some cardiac effect. That's why our preference is that this infusion will be done slower, just not to add any volume overloads on the heart. And some of these visits could last more than the 3 hours that are required by the infusion because other tests have to be done as scheduled. We have here the centers that we are enrolling in. You can see we are in Cincinnati, at Cincinnati Children, Washington University, and UCSF here in San Francisco, Children's Hospital in Aurora, Children's Hospital in Philly, Boston Children's Hospital, Shriner Hospital in Portland, UCLA in Los Angeles, and last but not least at the Children's Medical Center in Dallas. Before I finish this, first let me extend my gratitude to this young men who agreed to be in this study. This is very alternative to accept to do study with an experimental drug. Our hope that we can bring a additional treatment to the whole population. What they're doing, it is cannot be rewarded back to. Our best reward is if this drug at the end work in this patient population, that we will make it available to them, and we get the approvals that this could be every single one. My sincere thanks to the families who take the time off to bring their sons to the clinic and take care of that, take all the time is needed. We know that attending clinical trials require a lot of times from you. The Duchenne community, that is, wherever I go, I get received with an open arm, and everyone tells me how much that they consider themselves as a family of FibroGen, that they are the cheerleaders. I would like to repeat this. I heard it so many times. They are the cheerleaders for this study. And I hope they know that we are the cheerleaders for all these patients. I would like to thank PPMD for their continuous support. They're helping us keeping the message out. We need to enroll this study. It's important that we can complete this study and to get this result. Any delays for us is only time. For this young man is more than time. It's a life experience. It's an important tool that they can add it in the arsenal to use it during their tough time. So, and then I would like to thank all the investigators and coordinators on this study. I know everyone is doing their best to enroll in this study, but possibly we need that little bit extra push, that extra hurrah. Let's bring every single patient interested. Every single family is willing to sacrifice and bring their loved one to this study into the clinic. Let's enroll this study and let's hope to complete it soon. My hope that what we will end up this year was 18 subjects. We are today very close to the end of October. I don't think we can bring 5 additional young men into this study. That's every one counts. Thank you for your listening, and please, if you have any question, I'm here to answer.
Okay, thank you so much, Elias. That was really interesting. We do have a few questions. So one of the questions is regarding the muscles that are targeted with this therapy. I think you mentioned that cardiac and heart are both targeted with this therapy as well as skeletal muscle. Is that correct?
Sorry, can you repeat this?
Sure. Yeah, the muscles that are targeted with Pamrevlumab, I'm really sorry. Do they include cardiac, diaphragm, and skeletal muscles, all three, or are they you were looking at
all muscles, including skeletal muscles? It targets all type of muscles.
Okay,
so skeletal muscles. And the question why we targeted non-ambulatory. I can tell you anecdotally, we thought this study would be easier and faster to enroll. That's one of the reasons that we went there. And second, because we felt that this is a group of patients that everybody is putting them on hold while they are the one who need attention earlier. So this is the reason we started in there. And not because we did not think. As a matter of fact, we already designed a study for an ambulatory patient with Duchenne. We have not started this study. As you know, every study requires resources from not only financial resources, drug resources, but at the same time require a manpower resources. So that was will be coming in due time. So we will not be. The study being extended by lead investigators of activity seen in the first 3 subjects. This is what was reported to us previously by some of our investigators, and they're insistent on us to make the study longer. That is these activities this week. We're trying to maintain ourselves blinded just to be unbiased. We are relying, because this study is unblinded, but we are not trying to take a look at the detail of the efficacy just not to bring bias to the study. But the investigators themselves are totally unblinded, and their opinion is important in this part.
Okay, so it was based on the unblinded investigators' perceptions of the results of the study for the first 3 patients that you decided to extend the study by a bit,
yes.
Right?
Yes.
Okay. I might just clarify a few other things as well. So regarding the Brooks scale, Gustavo, would you maybe want to discuss the Brooks scale and what a Brooks scale of 5 means, and how does that exclude people?
Yes. So, well, it's basically just a measurement that allows the classification of the upper extremity function. It can also aid in documentation of progression. So it's just a 6-point scale, and what happens is they go through certain assessments of the young man being able to raise his arms, to do just certain functional tests, and then it's graded off of that. In order to meet the inclusion criteria, there needs to be a specific score, which is well placed in terms of where these patients are. So we haven't seen this become a huge hurdle in terms of including subjects or patients. So, yeah.
Okay, thanks so much. And is there a placebo arm of this study, or is it just a dose-finding study?
It is not a dose-finding study. It is a study with a single dose, and there is no placebo arm in this study.
Okay.
There is no comparator in this study. We have a potential discussion with the regulatory authority to see if we have to have a placebo arm. Our concern, a placebo arm would be detrimental to enrollment. I feel during my last presentation at PPMD in Chicago, I asked the question of some of the parents of this young man, if this study have a placebo arm, would they enroll their loved one in this study? And every single one said no. So in this case, we will need your help. We need the help of the community of the Duchenne muscular dystrophy to help us bring the message. If it's truly we could not enroll the study or the extension of the study, if it's the agency required it to be placebo control, we will need your help to spread the word why this study could not be done. And if it's that true, and I do understand some of this concern of having a placebo arm in the study.
Okay, thank you so much. So I apologize. It's a single dose study without a placebo in a non-ambulatory population, which the community applauds your engagement with. So we really think that this is great. I have had a question in the past about switching from prednisone to Emflaza. Can you talk about whether or not that's an exclusion criteria, as well as if patients choose to start on Exondys 51, which is now an approved therapy, if that's an exclusion criteria or not as well?
Go ahead.
I can address some of that. So in terms of the switch of a steroid, that is acceptable while a patient is on study. And I'm sorry, your second question
was Exondys.
That also, so any other approved or investigational agent while on study is exclusionary.
Okay, so Exondys, if a patient is on Exondys 51 or chooses to use Exondys 51, that's an exclusion criteria, but Emflaza, a switch from prednisone to Emflaza is not exclusionary, correct?
Correct. And patients that are currently on Exondys 51 would be able to participate, but it would require the washout period as described previously, the 28 days.
Okay. But
I would like to answer the last question before I leave, because if there's a question about the resource constraint, and they consider that as a financial. I didn't say there is a financial constraint at FibroGen. FibroGen is financially is a stable company. I said it will require financial resources, require human resources, requiring in combination all of these that cause some restraint on adding too many trials at the same time. So I think that is the question is not specific, or the answer is not specific that the company have a financial restraint.
Okay, thank you very much. If parents are interested in joining the study, they can find your study on clinicaltrials.gov. They can also find the study on our clinical trial finder on Duchenne Connect. We will be happy to answer any questions and direct you to the correct resource, as will the FibroGen team, I'm sure. Would you like to give any concluding remarks, Gustavo or Elias?
I will say, first of all, thank you so much for hosting us and then hosting this webinar. Second, this is we promised before, we continue to promise that we will do our best to complete this study, to get the outcome of this study, if it's positive, to be able to move forward to bring this drug to this patient as soon as we could. I would thank everyone for helping us this. As you see, Jessica Sharpently just joined the program at the same time as the program manager. If you have any question, if you need, her email address is listed and her phone number is listed. Please don't hesitate to contact her in whatever question you have. We will be pleasantly willing to respond to your question.
Thank you so much. We truly appreciate the dedication that your company has to this community, and we look forward to continuing to work with you. Thank you so much for this webinar.
Thank you.
This concludes our webinar.